I am Dr. Nitin Dhochak. I will be discussing about overview of COVID-19 in children. We will discuss briefly about the SARS coronavirus 2, epidemiology of COVID-19 and how the pediatric disease differs from rest of the age groups. Early in December 2019, there was an outbreak of acute respiratory illness in Wuhan city, China, and the number of cases kept increasing by late December. It was thought to have spread from Huanan seafood market, where various wild animals were being sold. The disease had marked similarities to the SARS outbreak of 2002 and 2003, and subsequently the etiological agent was identified as a novel coronavirus. WHO labeled the disease as coronavirus disease 2019 or COVID-19, and International Committee on Taxonomy on Viruses named the virus as SARS coronavirus 2. The virus was first isolated on 30th December 2019 from bronchoalveolar lavage samples. Coronaviruses have been causing infections in human beings previously also. These are spherical, medium sized enveloped viruses with positive sense single stranded RNA. They cause respiratory, gastrointestinal and central nervous system infections. Coronaviruses are genotypically classified in 4 subfamilies: alpha, beta, gamma and delta. Alpha and beta groups cause human infections. Viruses causing previous pandemics including Middle East respiratory syndrome and severe acute respiratory syndrome and the current COVID-19 pandemic belong to the beta group. Genome-wide analysis have shown that SARS coronavirus 2 shares nearly 80% and 50% sequence identity to SARS coronavirus 1 and MERS coronavirus respectively. This is the structure of SARS coronavirus 2. It has nucleocapsid composed of genomic RNA and phosphorylated nucleocapsid protein. On the surface, it has spike glycoprotein trimer S, heme agglutinin esterase He, membrane protein M and envelope protein E. ACE2 receptor on human cells is the target site where S protein binds and subsequently enters human cells. Coronaviruses have previously caused pandemic, although the number of cases were not as high as COVID-19 pandemic. It caused severe acute respiratory syndrome in 2002-2003. The virus was first detected in China in November 2002 and affected 26 countries later. It infected more than 8,000 people with a mortality of 10%. No new SARS infections reported since 2004. Later in 2012, another coronavirus caused Middle East respiratory syndrome pandemic. It first started in Saudi Arabia. Nearly 2,500 cases were reported with a mortality of 35%. The current pandemic is ongoing since December 2019. Briefly recapitulating the timeline of COVID-19, it began in Wuhan city, Hubei province and probably from the Huanan seafood market. This is the publication on early cases and transmission dynamics of COVID-19. This picture highlights the series of events in December and January related to COVID-19. As we can see, cases of acute respiratory illness started in early December 2019. As highlighted, few cases were associated with seafood market exposure and few were not. Early in January, WHO was notified regarding the outbreak of illness. On January 8, China CDC announced that a novel coronavirus as the causative agent for this illness. By mid-January, cases were also reported in Thailand. Subsequently, the number of cases increased in China and in other countries. By mid-March, outbreaks have occurred in Europe, USA and Japan. WHO declared COVID-19 as pandemic on March 11, 2020. In India, first confirmed case was reported in Kerala in January 2020. As of 20th August 2020, there are about 22 million cases with nearly 8 lakh deaths worldwide. In India, nearly 3 million cases are reported with 54,000 deaths, and these numbers are increasing day by day. Then discussing on COVID-19 infection in children, since early January there have been cases of COVID-19 in children in China. In this article, they have described 6 confirmed children of whom 1 required intensive care. This retrospective data showed that of 2143 children, majority were having mild illness in 51%, 38% had moderate illness and around 6% were severe and critical. And it was suggested that children are less affected and most are either asymptomatic or mildly symptomatic. Data from AIIMS Delhi also shows almost similar findings. Children less than 10 years constitute only 3.8% of the total COVID-19 cases and nearly 12% of all cases in age group less than 20 years. So, why are children less affected? Multiple explanations have been given for the same. One reason is less exposure in children. Due to lockdowns, children do not have much of outdoor activity and there is less contact with peers at the usual hotspots for respiratory viruses, including schools and daycare centers. They probably have strong innate immunity due to repeated viral infections and probably vaccinations. They have a healthy respiratory tract due to less exposure to cigarette smoke and pollution. They have less frequency of underlying comorbid conditions including diabetes, hypertension and others. The receptor for SARS coronavirus 2, the ACE2 receptor expression varies with age. It may have protective effect in lungs by limiting inflammation and capillary leak. And the regenerative capacity of alveolar epithelium is high in children compared to older adults. The clinical features also slightly vary from adults, like less frequency of fever in children reported in various studies. Nevertheless, most common symptoms in children include fever and cough. Majority are asymptomatic or mildly symptomatic. The severity classification of these children is based on WHO guidelines, which includes mild, moderate, severe pneumonia and critical cases. Treatment depends on severity of illness. In mild cases, home management is done. It includes symptomatic treatment including paracetamol, antihistaminics, ensuring adequate oral intake and isolation as feasible and watch for danger signs. In moderate to severe cases, hospitalization is needed. The treatment includes respiratory support, hydroxychloroquine in moderate to severe cases, remdesivir, convalescent plasma and tocilizumab may be used in selected severe cases. Then in end of April, there was an urgent alert by Pediatric Intensive Care Society from United Kingdoms. They had seen increased number of cases requiring intensive care admissions with hyperinflammatory state resembling toxic shock syndrome and Kawasaki disease. Then few case series resembling Kawasaki like illness have also come up. Then a large case series of multisystem inflammatory syndrome was reported from United States, which included 186 children. Few case reports and series have been published from India also. Later, this hyperinflammatory syndrome was designated as multisystem inflammatory syndrome in children temporally related to COVID-19, also known as MISC. Various pathophysiological mechanisms have been postulated for MISC. Delayed hyperinflammatory response to SARS coronavirus 2 infection and a post-infectious inflammatory state are the most probable mechanisms. Other proposed mechanisms are inhibition of type 1 and type 3 interferon response by the virus initially and then delayed cytokine storm, or probably the virus acts as an intermediate trigger or portal for entry of unknown trigger. So, with all these mechanisms, it leads to cytokine storm and end organ dysfunction. Frequently, children with MISC present with GI symptoms and cardiovascular system dysfunction. Kawasaki disease and toxic shock syndrome are important differential diagnoses. Diagnosis of MISC is based on criteria laid down by WHO or CDC, which includes clinical features, elevated markers of inflammation, evidence of COVID-19 infection or contact, and other common causes should be ruled out. Steroids and IVIG are first line drugs. Other treatment options include interleukin 6 and interleukin 1 inhibitors. Prognosis is good with appropriate treatment. To summarize, COVID-19 is a global health problem which affects children also. Most children have mild infection, but they should be appropriately monitored for severe disease. One should be aware of MIS-C and timely therapy should be administered if MIS-C is detected. Thank you.